Okay, so good afternoon, everyone, and a very warm welcome to today's session. I'm Shweta, and I'll be moderating today's OCI SIG Public Health webinar from screening to site, best practices in community vision screening programs. On behalf of the Optometry Confederation of India and the SIG Public Health team, thank you for joining us. Whether you're a student, a practicing clinician, a public health professional, or simply someone who cares about community eye care, this session is designed for you. Every vision screening carries the potential to change a life, but only when it leads to timely, appropriate care. Today, we'll unpack what it actually takes to plan, run, and strengthen a community vision screening program that delivers on that promise. So, before I begin, just a few quick housekeeping notes. Please keep yourselves in mute throughout the talk to avoid background noise. You can use the chat box to drop in your questions as they come to mind. We'll pick them up and end during the dedicated question answer session. And the session is being recorded, and the recording will be shared on the OCI SIG Public Health group afterwards. So, with that, let's get on to it. And just before I introduce our speaker, I wanted to spend a few minutes setting the larger context. So, for why such a conversation on community vision screening matters right now, because it connects directly to a global commitment that India is a part of. So just bear with me as I share my screen. Yeah, so okay, I hope my screen is visible. Yes. So just a second, I'm having difficulty with the settings. Yeah. So in 2021, at the 74th World Health Assembly, WHO member states, including India, endorsed the first ever global target specifically for refractive error. The target is actually a straightforward but ambitious, a 40 percentage point increase in effective coverage of refractive error or EREC by 2030. In simple terms, if a country's effective coverage stood at roughly 30% in 2020, the goal is to push that to around 70% by 2030. This matters because uncorrected refractive error remains the single leading cause of vision impairment worldwide, and globally, only around 1 in 3 people who need spectacles actually have a pair that properly corrects their vision. It's one of the most cost effective health interventions there is, and yet the gap remains enormous. To help countries actually get there, WHO launched the SPECS 2030 initiative, calling the coordinated action across 5 pillars. The letters of SPECS itself stands for service, personal, education, cost, and surveillance. It's a call to every stakeholder, government, professional bodies, private sectors, not-for-profit, to work together on scaling up access, building workforce capacity, raising public awareness, bringing down costs, and strengthening how we track progress. So for India, this is not an abstract global goal. Cataract and uncorrected refractive error remain the leading cause of blindness in the country, and closing the gap will depend heavily on the strength and reach of our eye care workforce. This is exactly where the optometrist workforce steps. With the National Commission for Allied and Healthcare Professions Act 2021, optometry in India now sits within a formal national regulatory framework for the first time, bringing standardized education, registration, and practice standards to the profession. Alongside this, a new competency-based curriculum for optometry has been rolled out, aligning training with national and global standards of care. What this means practically is that optometrists are increasingly recognized as the primary point of contact for refraction, detection, and basic eye health, working alongside ophthalmologists to extend the reach of eye care, especially into the underserved and rural communities where screening programs matter most. So this, you know, when we talk about community vision link today, so we are really talking about the frontline mechanism through which India and optometry specifically can move this needle on Specs 23rd. A screening camp that doesn't lead to a dispensed pair of spectacles or a refill that's actually followed up is a missed opportunity against this larger target. That's exactly the gap our speaker today has spent his career doing. So it's now my pleasure to introduce our speaker for today, Mr. Dabri Comrade. Mr. Comrade is a senior consultant optometrist with over 18 years of clinical leadership and public health experience across South Africa and India. He currently leads an eye clinic serving rural Himalayan communities in North India at Landore Community Hospital and Samvedna Disability Rehabilitation Center in Mussoorie, Uttarakhand, where he works alongside multidisciplinary teams to develop clinical services, conduct community outreach, train healthcare professionals, and improve access to quality eye care in underserved population. So without further ado, I give it over to you, Mr. Comrade, or please go ahead.
Thank you so much, Sweta. I'm going to just get ready to share my screen. All of you can see my screen there, eh? Sweta?
Yes.
Perfect. Okay, so first of all, welcome everyone. It's so nice to have all of you join today. And I first of all want to say thank you to OCI, the Optometry Confederation of India, Harshada and Sweta for this amazing invitation. It is really truly an honor just to spend this next hour with all of you, colleagues who all share a common passion. To all of us wants to restore sight, to improve people's lives, and to strengthen eye care in communities that we serve. So, although I'm speaking from the beautiful foothills of the Himalayas, I know that many of you are serving in completely different settings. Maybe you are working in a busy private practice, or maybe hospitals or NGOs. Or maybe you're working in a university setup, or maybe you're part of a big outreach program across India. But despite our different workplaces, I believe we all have something in common, and we chose this profession because somewhere along the journey we discovered that helping another person to see is one of the greatest privileges that we can have, and that passion is what brought every one of us here today. So today, I'm not going to just give you another lecture because you can do that online with lots of different platforms. But these mountains in the past years here in North India have taught me many lessons that I hope will encourage you in your own community and maybe in your own personal life as well. But before I start, I just want to start off with this, and it just summarizes my whole talk is the purpose of screenings, eye screenings, is not just to examine as many eyes as possible, but it's the purpose really of screening is to change as many lives as possible. So before I kick off, I'm going to just go to the first slide there, and let's just look at some statistics or some evidence. So I'd like us to remember why our work matters. So according to the WHO's World Report on Vision, there's approximately 2.2 billion people worldwide that lives with vision impairment or blindness, and at least 1 billion of these cases are preventable or haven't been yet addressed. So the leading causes, and we know this, are the conditions that we deal with every day. It's uncorrected refractive error, it's cataract, it's glaucoma, diabetic retinopathy, it's age-related diseases. But perhaps the statistic that challenges me the most isn't about the disease, it's actually about the access to good eye health care. Because for millions of these people, the greatest barrier isn't a lack of treatment, it's simply the inability to reach it. And I see that so often where we are in the rural mountains. And lastly on this slide is the Lancet Global Health Commission reminds us that achieving universal eye health isn't just about increasing our services, but it's actually about ensuring high quality, people centered eye care that is accessible to everyone, especially those in the most underserved communities. So that is where every one of us comes in and where we play a very big role. But as I shared, I'm not just going to give you another lecture. I want to share some stories with you. So just showing you this photo. This is one of the villages we work in. It's quite rural, and just to give you some context, just of where we work in. So for the past few years, just working in these rural communities, I had the privilege of leading an eye clinic in India, in the beautiful North India. And many of our outreach clinics begins with sometimes just 1 hour drive away, sometimes it's 8 hours drive away through winding roads, and sometimes we continue on foot. We stop and then we start trekking. Sometimes we arrive after navigating landslides and rockfalls, depending on the season. Like this year, or this season that we now is monsoon, so lots of rain and landslides. And every single time I'm reminded that people aren't waiting just for me or for us as a team because they want an eye test. No, they're waiting because lots of them, they waiting for an answer, or they want an answer, or they're just looking for hope in their eye journey. So I want to share a story with you of a lady that I'll never forget. A few years ago, we traveled up in a small village in the mountains, and we conducted a vision screening program. And among these patients was this elderly lady who had never had any eye exams, no comprehensive eye examination in her whole life. And her vision was so poor that she had simply accepted it as part of getting older. She assumed that this was just how everyone sees in the world. So the only way she could read was by holding that single lens that you see on the picture there, a very old magnifying lens, holding it close to her eye. It was scratched, it was worn, it was just barely usable, but it was all that she had. And as we spent some time just talking with her, not rushing things, but just talking with her, we discovered something else, that she wasn't only looking after herself, she was the full-time caregiver for her teenage son who lives with global developmental delay. And every day she helped him eat, she helped him get dressed, washed, helped him move around, looking after his daily needs, all while struggling to see clearly herself. So we examined her eyes, we prescribed her first pair of glasses, and a short while after that, she received her glasses. And for the first time ever, she could clearly see the mountains around surrounding her village. But something that really struck me that day was the greatest gift wasn't that she could now see the mountains again, but it was actually that she could now better care for her son who was so dependent on her. And the glasses didn't just improve one person's vision, it improved the quality of life of that entire family because she cares for them, and specifically her son. So that day really taught me something that I've never forgotten. And that is, if we look at this, the purpose of screening is not to examine as many eyes as possible, but the purpose of screening is to change lives, not to just simply examine eyes. Because every person, every patient that we see has a story. Every community that we go to has a story, and every screening program should honor both of those, not just one. So today, rather than giving you another lecture now, I'd like to share you 4 lessons that I've learned up here in the mountains, and what the mountains have taught me about community eye care. Lessons about the people, lessons about quality, about trust, and lessons about what it really means to go from screening to sight. So the first lesson I learned surprised me as well. Spending time, yeah, I used to think community vision screening starts when I open up my vision chart, but I eventually realized it starts long before the first patient ever arrives. And that's lesson number 1. It's screening starts with people, not just their eyes. So before I start sharing, but yeah, so what does the evidence say? So evidence say, according to the WHO, that community engagement is recognized by the WHO as one of the key components of integrated people-centered eye care. So community engagement, actually engaging with the local communities and villages. So I want to start off with a question for you, as and I want you just to think about this: is when does a vision screening program actually begin? Is it sitting around a table starting to plan? And yes, that plays a big role, but is it maybe unpacking your equipment, switching on the auto refractor, or when you ask the patient to read that first letter on at the top of the chart? And for many years, I believed that was the answer, or yes was the answer on these questions. But the mountains taught me something completely different in this beautiful community. And community vision screening programs begins long before the first patient sits in our chair. it begins with the people itself and the villages. And I want to show you just this slide, people before patients. So one of the biggest lessons that I've learned is this. People don't come to an eye camp because they saw a poster somewhere. We don't have posters here. They come because someone they trust encouraged them to come here. Whether it maybe it was a school principal, maybe it was an ASHA worker, a healthcare worker, a village elder, or maybe a neighbor who has already benefited from our service. So community eye care is built on really on relationships, not just the equipment. And I'm grateful for the equipment that I have, but it's really built on relationships. And I remember when we first started traveling to some of these rural villages, I thought our biggest challenge would be carrying our equipment. And yes, sometimes we had to strap our equipment to donkeys and trek into the mountains, but I was wrong. That wasn't our biggest challenge. Our biggest strength wasn't our equipment, but it was the trust that had already been built over the years. So many of these villages had rarely seen an optometrist before. They've never seen or been to an eye clinic, and some of them have never had an eye clinic or someone coming to their village by uh, in their homes. But they already knew our hospital, so there was lots of things that happened before. They already knew our rehab center. They already knew that if we come to their village, we will genuinely care, not because of me, but because of the trust that's been built through over the years. So it began many years just before I even arrived here. Long before our first vision screening ever started, there were people that chose to listen. There were people that sat down with village leaders. There were people that met with school teachers. Um, some of my personal friends, they've trained community healthcare workers really well. They've visited families in their homes. And yes, they drank countless cups of chai because that's what we do when we do these eye screenings. We drink lots of chai. And they invested in relationships long before I ever provided this service. So today, when we arrive to conduct a vision screening, we're not starting from zero. We're standing on the shoulders of many people who have spent years earning the community's trust. And I believe that's one of the greatest lessons in community eye care. So people may come for an eye examination to you, but they really return because of a relationship that you have or have with someone else. And the WHO's integrated people-centered eye care strategy reminds us that eye care should not simply be delivered to communities. It should be designed with communities. So I'll say that again. With the WHO's integrated eye care strategy, they remind us that when we do these things, we should not just deliver these screenings to communities, but we should plan with and design it with the communities in mind. And eye care is not most effective when it is integrated into local eye health systems and responds to the real needs the people it serves. So eye care is most effective when it is integrated into the local health system. So that sounds very simple. It sounds very, very simple, but it can be complicated, but it completely changes the way we think about screening. Instead of asking, how many people did we screen today? We begin asking ourselves, what does this community actually need? Sometimes, yes, it's some communities and some villages that need glasses, and sometimes it's cataract surgeries. Sometimes I go into villages and there's lots of people with cataracts. Sometimes it's just diabetic screening. Sometimes we focus more on the diabetic screening because we see there's undiagnosed diabetes or uncontrolled diabetes. Sometimes just need to intervene with low vision rehab with some villages with more elderly patients in. Sometimes it's simply just educating local people in the villages, or maybe teachers, because no two communities are the same. Every community in every village is different. And one lesson that I learned very quickly is that we cannot assume we know people's barriers. Some people don't attend some of the eye clinics because they cannot afford transport, or they're caring for children or elderly parents or patients. Some of them don't have anyone to accompany them, so they can't come. And some of them have heard frightening stories about surgeries, and others have simply accepted poor vision as just a normal part of aging. If we never ask these people, we'll never know. So it's so important to start asking to get integrated into these communities. We'll never be able to remove these barriers if we don't start asking questions. And that's why I believe one of the most important questions we can ask ourselves during any outreach program is not, can you read the bottom line, but it's simply, tell me your story. I'm sitting down and I want to listen. And yes, sometimes we don't have the luxury to listen to everyone's story. Sometimes we rush because there's 100 patients sitting outside. But we'll get to that. We'll get to that later, because behind every pair of eyes, there's a person, and behind that person, there's a family and a very big community. So people will rarely remember your refraction, but they will always remember how you made them feel. And I see that. I mean, after 18, 19 years of experience, people come back because of how you made them feel, and the time that you invested in them, and they really come back. And I'd like to leave you with one practical challenge before we move to the next lesson is the next time you organize a vision screening program, don't begin just by asking what equipment do we need. Yes, I would say that's the basics of planning. But begin by asking, who do we maybe need to meet up with? Because I truly believe screening doesn't start just with the eyes. It really starts with the people on the ground. And once we begin with those people on the ground, something else becomes really incredible important, and that's quality. And that's where I want to, but that's what brings me to my second lesson of what the mountains has taught me, and that is quality matters more than quantity. But if we just look at what evidence says again, nearly 1 billion people worldwide have vision impairment that could have been prevented or has yet to be addressed. So I'm going to say something that may sound strange in public health, but I don't believe success of a screening program is measured only by how many people you screened. I believe it's measured by how many people received the right care afterwards, because 1,000 poor quality screenings don't necessarily improve vision, but one high quality screening that leads to the right treatment can change an entire family and can impact a whole community. So I recently heard someone proudly coming to me actually in this week saying to me, they completed 5,000 eye screenings in 2 weeks. So my first thought wasn't, wow. I mean, even though it is quite impressive, but my first thought wasn't, wow. My first thought was actually, wow, what did those screenings actually involved? Just thinking about just rushing through patients, maybe missing really important stuff. And on this note, I just want to just share a few stories with you. So recently, in the last month, I two different ladies. The one is 15 years old, the other one in her mid-30s. The 15-year old, she came in with her family, all of them coming in for a routine just eye screening, and she coming in, no complaints, oh, having headaches now and again. We started just talking to them, and starting with her visual acuity. Her visual acuity is 6.9. Vision after doing refraction, her visual acuity is still 6.9. And actually digging deeper and checking out her retinas, we picked up early papilledema. Um, and a normal eye screening turned into something quite big, and we could refer her, and we still have a really good relationship with this family, just walking this road with them. The second patient, the same. She's in the early 30s. She actually, one of our orthopedic surgeons came on a screening with us, seeing patients, and he referred, at the screening, he referred her to me because she came in with some other neurological and this physical problems. And as we also checked, vision is slightly was deteriorated quite a lot. Um, and when we checked the retina, she has severe papilledema. So in the same case, we could have referred her and make sure that she receives the right treatment. Another story is one of our psychiatrists that also works with us, that also goes on some of these screenings with us. So we have a multidisciplinary team going out to some of these screenings so that we can have a bigger impact. So you referred this patient to me, and she just felt uncomfortable for the past few months, and she can't really explain what's wrong with her. And while doing screening, everything is perfect. Visual acuity, there's no prescription, but there's just something not right. And I just did one of my preliminary testings, doing a pursuit eye movement test, something that we so often sometimes in screening skip, because why is that important? So as I did do some slight motility testing, I picked like a slight a slight a tremor while she's doing some of the eye movements, and it disappears and then it comes back. Um, and we picked up some other neurological things, so we could refer this patient for an MRI, and we picked up a 1.5 millimeter tumor on her brain. I mean, that's massive, something that we could have missed so easily. Another elderly lady, she came in with saying that she's struggling with her vision. And because it's been so gradual, her vision changing, she didn't realize. I actually saw her moving her face and trying to find the words on this on the chart. And we did just a visual field testing, just a normal a normal testing, and we picked up that she has some visual field loss. We also sent her for an MRI, and we picked up a pituitary gland, and she had surgery, and she's doing well now. And just one more story. Also at a screening, a patient, middle-aged man, came to us. So we'll do blood pressure. Sometimes we'll do GRBS, sugar testing before we even start. And this patient came in with very high blood pressure. And as we were testing, I also picked up early hypertensive retinopathy on his retinas. And because of that, we referred him for some extra just ECGs and things. And the very next day, he had to get a stent. He almost got a stroke. So really small changes and just spending time listening to patients can really impact a patient's life, or actually impact their life. It's like a life or death situation in some of these cases. So one of the biggest mistakes that we can make in community eye care is really believing that larger numbers automatically means better. We love reporting numbers. I think most of the conversations that we have in eye care is, this is the numbers that we screen. And so often we feel, I'm not doing that much. But numbers alone doesn't tell the whole story, because the real question isn't how many people we screened. The real question is how many people's lives were actually changed. So I've learned something over the years, that a poor quality screening program can actually do harm. If we miss pathology, if we prescribe poor refractions, if our referral systems breaks down, then screening becomes just a little bit more than a public event, just to say that we've done that. So our responsibility as optometrists doesn't just end with someone walking away with a prescription or glasses. It ends when the patient really receives the care that they actually need. So one thing I always remind myself in eye camps is that the person sitting in front of you may have traveled for hours to reach you. Some have walked long distances, some of them missed their daily wages. Some of them have left family members behind. For some of them, or many of them, this is literally their only opportunity that they will have their eyes examined ever. So that completely changes how we approach and see the patient that sits in front of you. So it really reminds us that every refraction deserves our full attention. Every visual acuity really matters. Every referral really matters, because we may not, sometimes we don't get a second chance. So that's why I would rather screen fewer people well than screen thousands of people poorly. And I know there are amazing teams out there, very big teams. We're not such a big team, but that can do it very well with big numbers. But the majority of us, we don't have those privileges. And I would rather detect one child with amblyopia, or identify one patient with glaucoma, or refer one diabetic patient with sight-threatening diabetic retinopathy, than simply increase my screening statistics. Because screening isn't just about better quality or collecting, sorry about that. Screening is not just about collecting the numbers, it's about changing lives. And this, I feel this slide over here is so important. It's more isn't always better. Quality is always over quantity, and a screening program is only as good as its referral system. I'm going to say that again. A screening program is only as good as its referral system. So when we do an outreach camp, we should always ask ourselves, did we provide the right care for the patients? Because quality assurance isn't complicated. It's simply making sure that every patient receives that the the very next step, or the appropriate step. And if we look at this flow chart, I'm not going to go into detail with this. You can go and study this, and lots of you have seen this for us working in public health or doing eye screenings, we've seen this. But one of the simplest, this is really one of the simplest quality assurance tools that I've come across. And it's this referral pathway of the Community Eye Health Journal. And I want to encourage you not to overcomplicate screening. Screen consistently, refer appropriately, don't try to diagnose things in the field, know your limits, build a good referral system, and good screening doesn't try to do everything. Okay, and I want to, if we look at this slide over here, there's at the bottom you'll see there, do not stop here, and that's what I want to focus on. We shouldn't just stop after giving out those classes. Good screening knows exactly what it should do and what it should refer, what we should refer and what we don't need to refer. So if we look here, quality isn't expensive, but poor quality can be very expensive. And then I want to go over to lesson 3. And this says referral means understanding lives, not simply writing a refer letter. But let's see what does the evidence say. The evidence says studies from community screening programs report that only 30 to 70% of patients successfully complete referrals depending on local barriers. I've had many patients, unfortunately, where initially starting off writing referrals and then after 3-4 weeks, I go back and then ask, oh, did you go? I don't know, I lost my referral. And then, I mean, that's how we learn how important it is to do these follow-ups and to check in with these, with when we refer. And that's why I'm so grateful for some of our community healthcare workers that can do all of this for us, because as Optums, we can't do everything. But so far, we've talked about screening the right people and providing quality screening. But quality screening has one purpose, and that's to help people receive the right treatment. And if treatment never happens, then the screening actually has failed. So referral isn't the finish line, as that diagram has showed us. It's where the real work actually begins. And that actually also sometimes takes a lot of time. So a referral is not the end of the screening. A referral is the beginning of our care. So I want to share another story with you. It's one of my patients. A few months ago, I met this elderly woman who required cataract surgery. Afterwards, I sat with her, I explained, me and my assistant, we explained to her the procedure of the cataract surgery, and we began just discussing how we could arrange her referral. And she listened very patiently, and then she asked, can't you just give me some eye drops instead? I think many of us have had that question. And I explained that yes, eye drops cannot cure a cataract. She then shared her reality with me, that she was the primary caregiver for 8 family members. Taking a day off of working in the fields and providing for them, making them food was simply not an option for her. So traveling 3 hours to the nearest city for surgery, staying away maybe a day or two for recovery, and leaving her responsibilities behind was simply impossible in her world and in her context. So as we try to offer different solutions, like every option that we suggested was met with like almost another challenge. And not because she didn't want the treatment, she really wanted the treatment, but because the circumstances almost made it impossible. So that conversation just really taught me something. No textbook, no lecture, no training course ever could have taught me. And healthcare is not just about diagnosing disease and knowing treatments. It is really about understanding the lives that people return to after they left our clinic. I'm going to say that again. It is really about understanding the lives that people return to after they leave our clinics, getting into their world, understanding how they do their lives. The best solution on paper is not always the best solution in reality. Um, and working in rural and remote communities has taught me that effective care often requires us like thinking out of the box, thinking out of what we studied at university, but thinking just a little bit out of the box, thinking beyond our clinical guidelines and entering the world of the person that's really sitting in front of you and entering their culture, understanding their responsibilities, trying to work through some of their fears. We have so many patients that really has a fear for getting surgery, working through their daily struggles, that all of this really matters just as much as the diagnosis itself. And that's why we need a team around us. And we should ask ourselves, what happens after they leave? Instead of asking ourselves, did we refer them? Did we just give them that referral letter? We should ask ourselves, did they arrive to where we referred them? Were they examined? Did they receive the right treatment? Did they maybe improve after that treatment? So the referral slip is only a piece of paper. The real journey actually starts when the patient walks away. That's where the real journey starts for them and for us. So every referral has barriers, and I think all of you streaming in today and listening to me, you might have different barriers in your settings. But for us over here, it's distance is quite big, just the tough terrain, the mountainous terrain. Sometimes it's money, sometimes it's getting time off their workplaces, family responsibilities, fear, lack of transport, lack of understanding. This is quite a big one. Disability. We have so many disabled people up here in the mountains, cultural beliefs. So we often assume that once we hand someone that referral letter, my job is finished. But for the patient, their difficult journey is only beginning then. So this is something I see regularly up here, and sometimes the eye condition isn't actually the biggest problem for them, but actually getting that transport that they need, that money maybe, or the family support, just someone going with them. All of you know, a surgery, they need someone to take them. So we as optoms, we don't just simply prescribe glasses. And sometimes people think that that's what we do, but that's not just what we do. We don't just manage cataracts. We don't just see diseases. We really serve people. We serve families. We serve people with fears, people with really big responsibilities. And I feel that the best screening teams really becomes people that's really great problem solvers, to think out of the box, as I've shared previously. So sometimes solving that transport problem really helps more than writing another referral. And I just want to emphasize this again, is don't overcomplicate screening. Screen consistently, and I'll speak about this in the next minute. Refer appropriately, make sure that you make the right referral. Don't diagnose everything in the field. Sometimes we try to do everything. We are not Superman, we're not Superwoman. Know your limits, stay in your lane, build a good referral pathway, build those professional relationships around you that you can refer to and that you can also trust, and measure what happens after referral, not just how many referrals you made. So I'm going to read this to us. It says, good screening doesn't try to do everything. Good screening knows exactly what it should do and what it should refer. What it should do and what it should refer. So referral isn't just paperwork. The referral is a big responsibility. So in other words, a referral is only successful when the patient receives the care that they need. So in the closing, or just closing up lesson 3, quality screening isn't measured by the number of people we examine. It is really measured by the number of lives that are actually impacted and changed. So going into the last lesson, lesson 4, communities remember consistency. Great eye care is never done alone. So what does the evidence say? Evidence says sustainable community eye care programs depend on long-term partnerships between communities, primary care providers, hospitals, and rehab services. So as I look back over the past years working here in the mountains, one lesson stands out above all the others, and this is communities don't remember one good eye camp. They remember the people who keeps coming back. Trust is built through consistency, 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 and consistency is never achieved by just one person. We can't do things on our own. And although I'm an optometrist, I'm only a small part of a much bigger team. Every day I have the privilege of working with a orthopedic surgeon, family physicians, a gynecologist, occupational therapists, physiotherapists. We have social workers, we have nurses, we have community health workers that we train regularly. We have psychiatrists, we have dentists. So all of us sometimes go together on these screenings so that we can help one another. And each of us sees only a part of the picture, but together we care for the whole person. And one of the greatest lessons community eye care has taught me is humility. Humility. Knowing when to ask for help, knowing when someone else is better equipped to meet the patient's needs. So great community eye care is never built around just one individual. It is built around relationships between professionals, between different hospitals and communities, and most important, between our patients and us. So one screening can change a day. Consistent care can change a community. So when I first moved to India, I thought my job was simply just to examine eyes, and all of us know this, it's not true. Over the time, I realized that our real job was removing some of these barriers sometimes. And sometimes these barriers were distance, some fear, lack of awareness, sometimes just helping people believe that they really deserve better vision. Some people, they just get so used to that. But people really deserve better vision. But I also just realized something else, that none of us can remove those barriers alone. It really takes a team to do it. It takes partnerships, it takes consistency. And that's how communities begins to trust us. So as I'm going to end off, I want to end off with a rhetorical question, a question that you don't need to answer, a question I want you to just think about. You can take a photo of this or a screenshot of this, and you can go and think about this, or maybe take this question to your teams and ask them these questions. And this question is, what will your community remember about your eye care program 5 years from now? Will they remember one successful screening day? Or will they remember a team that consistently cares for them and regularly comes back? So that's just a question I just want to throw out there and just want you to think about and maybe take back to your teams to think about. And then what I'm going to do is now is, before I give over to Harshada or Shweta, I'm going to just ask you two questions. So before you ask me questions, I don't always have all the answers. We always stay students, we always learn. But I would like to ask you two questions, and I want to, in your setup or in your setting, I want you to, for those of you that's comfortable, please answer these questions. I'll give over to Sweta now. The first question is, what is the biggest barrier preventing patients in your community from receiving eye care after they've been screened? That's the first question. And then the second question, I'll go back to these questions, is if you could improve just one part of your current screening program tomorrow, what would it be and why? What would you change? So at the end of the day, our success isn't measured by how many people we screen. It's really measured by how many lives are genuinely changed. So I'm going to stop sharing my screen. I'm going to give over to Shweta to facilitate our questions and answer session. And I can repeat the questions again if you want me to. Thank you, Shweta.
Yeah. Thank you so much, Dabri, for that, an inspiring session. All your four lessons definitely inspired us to do more. So yeah, the participants, if anybody wants to unmute and answer the questions asked by the speaker, please go ahead.
So I'm just going to repeat that first question if someone wants to answer that first question within their context. So what is the biggest barrier preventing your patients or in your community from receiving eye care after they've been screened? I'm just going to say that again. What is the biggest barrier? Like for us, it's maybe the distance, maybe just local challenges in the villages. What is your biggest barrier preventing patients in your community from receiving the right care after they've been screened?
If anybody wants to unmute, or please you can put in the chat box also if that is.
Mohit Wasim, did he maybe raise his hand
Yeah,
or
Wasim, did
just
you
a
raise
thumbs
your
up?
hand? Okay.
And I'll ask the next question as well. Maybe you can reply on this is, if you could improve just one thing in your current screening program, what would it be and why? What would you change in your current screening program? What would you like to change in your current screening program?
Okay, Dabri, I think Mr. Sudhanshu has answered for the first question that he's put in the message. The biggest barrier is community awareness.
Yes, that's a big one. Maybe somebody else can put in the box or can put on their video and talk to us.
Yes, participants. Yeah, yes. Paula is saying closing the loop, patients being referred to higher center don't end up visiting actually, after the referral has been done.
Yes,
So that is one. Deepak sir is saying barriers in our setting are multifold, including, cost of travel, consultation, need of escort, and
yes.
felt need some time. Yeah.
I just want to add to that one that said closing the loop, patients being referred to higher centers don't end up visiting. I think that's quite a big one. Anisha, I saw that, and I think something that really helped me or our team was giving, for sometimes a lot of us, we are overwhelmed with lots of work and patience. So I think really have someone or that has a designated, almost like some of our healthcare workers, we we check in and make sure that they follow up with these patients. Sometimes they even go with these patients to these institutions so that they can do the referral system. So actually getting someone to do that work for you, and someone that you can trust. I have especially two people that works with me that I can trust and say, please follow up with that patient, make sure that they get the right care. But I mean, it always will stay a challenge, especially elderly patients that sometimes have fears in going to these places.
Yes, you can see the comments on the chat box. Okay, for the improvement, he says that all the kids after screening are selected gets their correction after getting a cycloplegic refraction.
Yeah. I love it that you say cycloplegic refraction. What I've seen sometimes, I've seen people doing screenings with kids with autorefractors, and all of us know they accommodate. So then you get minus 5, 6, 7, 8 prescriptions, and then they give it to the children, and then they come to us and they say they struggle. So I like it that you said you do cycloplegic refractions or just a simple retinoscopy. And just a simple retinoscopy, Mahindra retinoscopy, MEM retinoscopy, all of those things can really tell you a lot if you don't necessarily have the time to do a cycloplegic refraction.
Okay, Maheshwari is commenting lack of awareness, difficulty maintaining quality assurance, and inadequate community mobilization as well. Yes.
Yeah. And that comes with time. Sometimes that comes with, as I've shared, it comes with building relationship with the community. Is there anyone else after I've asked my questions that maybe wants to ask questions to me?
Yeah, we have two questions. Shweta, I think you can take them.
Yeah. So we had two questions in the chat box. Just a second. Yeah. So the first was, what strategies have you found effective in reducing patient dropout after screening?
Yes, very good question. I think one of our biggest strategies that I've shared is, so we have healthcare workers like ASHA workers in our rehab center, and it's like a local clinic that we've established up in the mountains. So we've trained about 25 healthcare workers or ASHA workers. So each one of them comes from a different village. So each one of them from those different villages, they know their people. And whenever they bring their people to wherever we do our screenings, if it's at the village, we make sure and we train them really well to make sure that they do the follow-ups and that there's no dropout. And yes, of course, there will always be dropouts. Unfortunately, sometimes they just don't do their work, or something happens. There's a marriage in the village, and then life just happens, and people forget. Or there's a landslide, and the whole village gets wiped away. So sometimes there's other factors that also plays a role. But I feel having a team that can do that for you and for us, it's definitely our healthcare workers. And then I would say our healthcare workers are ran by a social worker. She's the head, a community social worker, and she makes sure that all of these healthcare workers actually do their work.
Yeah, thank you for that. And the next one was, Ms. Paula is asking, what is the importance of scientific dispensing, and do you think it improves compliance perspective?
Yes. If you can maybe just elaborate on the scientific dispensing, you mean specific with dispensing glasses to patients?
Yeah, dispensing spectacles, we take measurements like PD, whether the frame is fitting, all those.
Yes, yes. Yeah, so that's something I'm actually very passionate about. And I regularly see referral letters and prescriptions from other healthcare workers, and I almost never see a PD. I almost never see anything else. And that's one of the first things that I do before I even do a screening is start off with PDs. So I mean, just a simple thing like PD is very important. And yes, of course, a fitting. Sometimes we also see young children coming in with these big glasses and moving down the nose. High latent hyperopic patients coming. It's so heavy. They're looking over their glasses. So yes, dispensing is quite a big thing. And unfortunately, I like that question. That's it's quite a big of a barrier in our region as well. Is this having good trained, I would say, like optical dispensers that knows how to fit glasses when they receive the prescription to make sure that they give right type of frame and do the right fittings.
Yes. And I think we have a comment from Sudhanshu, like finding community health workers can be challenged in many places. Agreed. So that is yes. And the communication skills are essential for community health workers because that establishes trust. So yes,
Yes, yes,
agree.
I love that, and I think it, finding community healthcare workers, it's really it's very difficult, and I'm very lucky. I walked into a program that's been built for many years, and most of these community healthcare workers have literally worked there for 15 years. So that's something that I'm grateful for. But I can imagine getting into a community and trying to get these people to get on board, to catch the vision, sometimes is difficult. And we don't necessarily have the funds also to pay them big salaries. So I agree with you, Sudhanshu. It's definitely a big challenge.
And we have time for one more question. If anybody has any other questions, please feel free to ask. Okay, meanwhile, I just wanted to, understand from you, like you have experience working in India, outside India, in similar, community settings.
Yes.
So how do you think it differs, or like what are the similarities? So from your perspective.
Yes. So if I compare Africa with India, it's actually very similar. We also have very rural areas in South Africa. Some of the rural areas in Africa, I would sometimes say it might be much more rural, where there's no people ever coming to certain areas. And finances is always a big thing. The long distances is always a big thing. So I would actually say Africa and India has lots of similarities. So I think that's why I enjoy working here. It's just because most of the things that I've seen here, I've already seen back home in our country, in Africa. But I think something that really helped me as a young optometrist 18, 19 years ago was being exposed to these challenges, almost like trains you to think out of the box. And that really helps as you grow older to think out of the box.
Thank you. So I think we'll take one more question
Yes.
from Mr. Deepak Baga. How often do you see inclusion of low vision rehabilitation as part of, comprehensive public health programs?
Uh, Unfortunately, not a lot. Unfortunately, not a lot. Like our program, I'm also very grateful. We are also our base part of where we work from and do all our screenings is actually a rehab center that's filled with occupational therapists and physiotherapists. So what I'll do is sometimes when I pick up things, I'll train some of these OTs or PTs to do some visual therapy. But low vision rehab sometimes can be very difficult to resource the products and things that they need. Um, and actually then to get also to get a team of special needs people to work around these people. So to I would say, I mean, I don't see it a lot, but within our context, because we are privileged to have a rehab center, our people are trained quite well in working with these cases. But I think the biggest challenge is actually the physical devices and to procure those devices. Yes.
So I think just Gangna, like the question that you asked, how often like young fresh optometrists can get into public health or community outreach. So I think there are a lot of ways to get into either join as public health professionals and community optometrists who go and do work and research in the field, etc. And as OCI, we are conducting something called Career Connect, which is happening in August too. So if you are more interested to knowing about more opportunities in that, please feel free to register, and you'll get more information from our website. So it is free for optometrists to register, and you'll have more opportunities in public health along with other fields in optometry as well. So please feel free to check it out. So thank you so much, Comric, as we come to the end
Thank
of
you,
this
Shweta.
session. You generously shared your time and your on-ground experience with us today, and it's given all of us, much clearer and a more practical picture of what it takes to move screening into real sight-saving outcomes. So
Yeah.
thank you. And just before we close, I just have something to share. Yeah, so I hope the screen is visible. So this is just to give a snapshot of what we've been doing in the community. So as OCI, we've conducted over 2 lakh screenings in our past, 10 years of community outreach. And we've covered more states in India, and we have a pan-Indian, reach. And our flagship initiatives include school screening, which is experience vision and vision for a cause. Besides it, we also do community screenings like geriatric eye care, and also occupation specific screenings like farmers project, truck drivers, weavers, fishermen, etc. So this is just to give the reach that we've done as OCI with our multiple partners and with the support of our sponsors. And as we are here, I just cannot not talk about this. So this is a series that we are going to conduct for public health professionals. It can be an optometrist, it can be a program manager, it can be anyone who's dealing with public health. So OCI, in collaboration with Prasho, will be conducting a series of educational sessions in public health. So we are calling currently for nominations. The nominations will close by September, and the registrations we are planning to start by the World Sight Day this year, and the program actually begins in January. So anyone who's interested to know more about this and wants to nominate yourself or nominate a fellow colleague, please feel free to reach out to us through our official mail line. So, yes.
Thank you so much, Shweta.
Yeah, so thank you so much, W, once again for your time and sharing all that information to us. And to everyone who's joined, thank you for your time, your questions, and your engagement in the chat. As we discussed, closing India's refractive error coverage gap and moving towards SPECS 2030 target isn't going to happen through screening numbers alone. It depends on programs designed the way that we heard about today, with follow through built it from the start. And the recording of this session will be shared in the OCI SIG public health group. So feel free to revisit it or share it with your colleagues who couldn't join live today. And do keep an eye on OCI SIG public health group for our next sessions and more important sessions coming up in around SPECS 2030. So thank you all once again and have a great day. Thank you.
Thank you so much.
Harshila.